Infusion of solipinase alpha for CLN2 disease. Solipinase alpha has not been approved in Australia. The provision of the information contained in this video is not intended to be used to advocate for the use of solipinase alpha in Australia. Solipinase alpha is contraindicated in patients with life-threatening anaphylactic reaction to the active substance if re-challenge is unsuccessful, ventriculoperitoneal shunts, and acute intraventricular access device leakage, device failure, or device-related infection. This video was developed to help your team understand the infusion process for solipinase alpha. The recommended dose is 300 mg administered once every other week by intracerebroventricular infusion. Solipinase alpha should be administered first, followed by the flushing solution. The complete infusion time is approximately 4.5 hours.
Intraventricular delivery of a medication has been used for many decades already, especially in neuro-oncology, where it's being used to provide chemotherapy directly to the brain tumor inside the brain. Solipinase alpha is the recombinant human lysosomal enzyme tripeptidyl peptidase 1. It has large molecular sites which does not allow it to cross the blood-brain barrier. So if you would provide it as other lysosomal enzymes sometimes are provided via IV infusion, it would not be able to cross the blood-brain barrier and target the organ where it needs to be, which is the brain. CLN2 disease is a neurodegenerative disease, so we really need to target the brain, different from some other lysosomal storage diseases. So here really the target is the brain, so we need such an ICV device to allow the enzyme directly go to the brain where it's most needed. When you perform ICV infusion, it's very important to follow certain aseptic techniques, because the moment you puncture the device, you provide access from the inner side of the brain to the outer side. So there's a high risk of infection, and we feel it's very important to work strictly with aseptic techniques. Prior to the first ICV infusion, we sit together with the family, with the parents, and explain to them in detail what we are going to do and why we are doing this, so that they know what to expect and what's going to happen when. So they know that they would have to wear a cap and a mask, and that we gown ourselves up, that we work on a sterile technique, etc. We also try to give them the opportunity to watch an infusion in another child, so that they see how it's happening, and they also experience how relaxed the children are during puncture and also during infusion.
Chapter 1: Important Preparation and Administration Information. Aseptic technique must be strictly observed during the preparation and administration of solipinase alpha and flushing solution. Administration must only be by the intracerebroventricular route by a trained healthcare professional knowledgeable in intracerebroventricular administration in a healthcare setting. Solipinase alpha is infused into the cerebrospinal fluid, or CSF, via a surgically implanted reservoir and catheter called an intracerebroventricular access device. This device must be implanted prior to the first infusion and should be appropriate for accessing the cerebral ventricles for therapeutic administration. It is recommended that patients are pre-treated 30 to 60 minutes prior to the start of an infusion with antihistamines with or without antipyretics. Solipinase alpha should be administered first, followed by the calculated amount of flushing solution. Both infusions should be at a rate of 2.5 milliliters per hour. The complete infusion time, including solipinase alpha and the flushing solution, is approximately 4.5 hours. Chapter 2: Infusion Materials. For the proper administration of solipinase alpha and flushing solution, the following components are required: a programmable syringe pump, 2 10 to 20 milliliter single-use syringes, 2 single-use hypodermic syringe needles, a single-use infusion set, a 0.2 micron inline filter, a non-coring port needle with a gauge of 22 or smaller and a suggested length of 16 millimeters, and a single-use syringe for collection of the cerebrospinal fluid. All infusion components must be sterile. Chapter 3: Preparation of solipinase alpha and flushing solution. When preparing solipinase alpha and the flushing solution for infusion, aseptic technique must be strictly observed. Begin by removing the appropriate number of solipinase alpha and flushing solution vials from the freezer. Thaw the vials at room temperature for approximately 60 minutes. Thawing the vials outside the carton is recommended. Condensation will occur during this period, but do not thaw or warm the vials any other way, and do not shake them. Do not refreeze the vials. Inspect the vials to ensure they are fully thawed. Solipinase alpha should be clear to slightly opalescent and colorless to pale yellow. Occasionally, solipinase alpha may contain thin translucent fibers or opaque particles, but these will be removed via the inline filter. The flushing solution should also be clear to slightly opalescent and colorless to pale yellow. Particles may be present that dissolve when the vial is fully thawed. Do not use if the solutions are discolored or if other foreign particulate matter is present. Once completely thawed, solipinase alpha and the flushing solution must be used immediately. If immediate use is not possible, unopened vials should be stored at 2 to 8 degrees Celsius and used within 24 hours. Each vial of solipinase alpha and flushing solution are intended for single use only. Follow local aseptic protocols to prepare the thawed solutions for infusion. This may involve disinfecting hands. Label one unused sterile syringe solipinase alpha. Attach a sterile syringe needle to the labeled syringe, then remove the green flip-off caps from 2 solipinase alpha vials. Using aseptic technique, withdraw the required volume of solipinase alpha solution. This is 300 mg for 2 years and over. Do not dilute solipinase alpha or mix with any other medicinal product. Ensure the appropriate amount of solipinase alpha has been withdrawn and discard the needle and vials as per local requirements. Use the syringe immediately for infusion. If not used immediately, in-use storage times and conditions prior to use are the responsibility of the user. Label an unused sterile syringe flushing solution. Attach a single-use syringe needle to the labeled syringe. Remove the yellow flip-off cap from the flushing solution vial and withdraw the appropriate amount of flushing solution from the vial into the syringe. Discard the needle and the vial with the remaining solution as per local requirements. Use the syringe immediately for infusion. If not used immediately, in-use storage times and conditions prior to use are the responsibility of the user. Chapter 4. Preparation for infusion. As with preparation, aseptic technique must be strictly observed during administration. Follow local protocols to prepare to administer the infusion. These may include wearing a mask, a cap, and a sterile gown. Once the mask and cap are on, a thorough hand-washing protocol should be followed, using a scrubbing brush to scrub hands and antibacterial soap. An assistant, also wearing a mask and cap, should help with gowning up. It is recommended that everyone present in the infusion room wears a mask. Put on a sterile pair of gloves and gather together the items needed for the infusion. All components must be sterile. The items needed for the infusion include the solipinase alpha and flushing solution and a programmable syringe pump. You will also need 2 10 to 20 milliliter single-use syringes, 2 single-use hypodermic syringe needles, a single-use infusion set with an extension line if needed that is 150 to 206 centimeters long with a 0.1 centimeter internal diameter, a 0.2 micron inline filter, a non-coring port needle with a gauge of 22 or smaller and a suggested length of 16 millimeters, and a single-use syringe for the collection of the cerebrospinal fluid to check patency. It is recommended to have an extra pair of sterile gloves for changing lines, skin antiseptic solution such as betadine or chlorhexidine, gauze or another material to wrap the head with during and after the infusion, and a sterile patch or gauze for the infusion site post-administration. Some institutions experienced with intracerebroventricular infusion recommend covering all supplies with sterile gauze once removed from the packages to help maintain a sterile environment. Attach the syringe containing solipinase alpha to the extension line if used. Otherwise, connect the syringe to the infusion set. The infusion set must be equipped with a 0.2 micron inline filter, which should be placed as close as practically possible to the port needle. Prime the infusion components with solipinase alpha. Chapter 5. Preparing the patient. Consider instructing the parents in advance to prepare their child's infusion site, for example by using hair removal cream or washing the hair with antibacterial shampoo the night before. Numbing cream may also be applied prior to the infusion if necessary. 30 to 60 minutes prior to the start of infusion, it is recommended that patients are pre-treated with antihistamines with or without antipyretics. For the procedure, the child should be sitting up or positioned at a 45-degree angle. It is important to minimize their movement during the infusion process, so have a caregiver hold them gently from behind. They may help keep the child distracted to further minimize movement during the port access by showing them a movie or TV on a tablet or reading a book. The caregiver should consider wearing a mask to ensure the area above the child's head and the reservoir remains sterile. Vital signs should be monitored before, during and after the infusion in a healthcare setting. Upon completion of the infusion, the patient's status should be clinically assessed and observation may be necessary for longer periods if clinically indicated, particularly in patients less than 3 years old. Electrocardiogram, ECG monitoring during the infusion should be performed in patients with a history of bradycardia, conduction disorder, or with structural heart disease, as some patients with CLN2 disease may develop conduction disorders or heart disease. In cardiac normal patients, regular 12-lead ECG evaluations should be performed every 6 months. CSF samples should routinely be sent for testing to detect subclinical device infections. Hypersensitivity reactions have been reported in solipinase alpha-treated patients during the clinical studies. Hypersensitivity reactions may occur during the infusion or within 24 hours of completion of the infusion. The signs and symptoms observed concomitantly with hypersensitivity reactions included pyrexia with vomiting, pleocytosis or irritability. Symptoms resolved over time or with administration of antipyretics, antihistamines, and/or glucocorticosteroids. In clinical trials, the most frequently reported adverse reactions occurring at an incidence of greater than 20% were pyrexia, low CSF protein, ECG abnormalities, vomiting, upper respiratory tract infections, and hypersensitivity. Inspection of the infusion site and a patency check must be performed to detect intracerebroventricular access device leakage and/or failure prior to initiation of solipinase alpha infusion. Confirmation of device integrity may need to be confirmed by neurosurgeon consultation. Do not administer solipinase alpha if there are signs of acute intracerebroventricular access device leakage, device failure, or device-related infection. Prepare the scalp for infusion as per your institution's standard of care. Clinicians experienced with intracerebroventricular infusion recommend beginning the disinfection process by wearing 2 pairs of gloves and using 3 swabs, then removing the top pair of gloves to complete disinfection with the remaining 2 swabs. Insert the port needle into the intracerebroventricular access device. Some experts recommend positioning the needle so that the line is running towards the back of the head. If you do not successfully insert the port needle into the access device on the first attempt, restart the procedure from the beginning. When puncturing, avoid rotating the needle if possible and do not use force. If the needle does not go in slowly, check the reservoir position and usage. The needle platform should be flush against the skin so that it is stable. Connect a separate anti-sterile syringe that is no larger than 3 milliliters. Slowly withdraw 0.5 to 1 milliliter of cerebrospinal fluid to check the patency of the intracerebroventricular access device. CSF samples should routinely be sent for infection monitoring. Do not return cerebrospinal fluid to the access device. Attach the infusion set to the port needle. Remove the gripper wings from the port needle and secure the components in place as per your institution's standard of care. Chapter 6. Infusing solipinase alpha. The previously prepared sterile syringe that contains solipinase alpha and is connected to a primed infusion line should now be placed into the syringe pump. Program the pump to deliver at an infusion rate of 2.5 milliliters per hour. Do not deliver as a bolus or manually. Set the pump alarms to sound at the most sensitive settings for pressure, rate, and volume limits. See the syringe pump manufacturer's operating manual for details. Label the infusion line for intracerebroventricular infusion only and initiate the infusion. It is recommended that a caregiver stays with the child at all times during the infusion. Advise the caregiver to bring items to help comfort the child, such as movies, toys, favorite foods, music, and games. Throughout the infusion, periodically inspect the infusion system for signs of leakage or delivery failure. Vital signs should be monitored periodically during the infusion. After the infusion is complete, check that the syringe in the syringe pump is empty. Wearing sterile gloves, detach and remove the empty syringe from the pump and disconnect it from the tubing. Discard the empty syringe in accordance with local requirements. Chapter 7. Infusing the flushing solution. Once the solipinase alpha infusion is complete, prepare the flushing solution using sterile gloves. Attach the prepared syringe labeled flushing solution to the infusion components. Place the syringe containing the flushing solution into the syringe pump and program the pump to deliver at an infusion rate of 2.5 milliliters per hour. Do not deliver as a bolus or manually. Set the pump alarms to sound at the most sensitive settings for pressure, rate, and volume limits. Periodically inspect the components during the infusion for signs of leakage or delivery failure. Vital signs should be monitored periodically during the infusion. After the infusion is complete, check that the syringe in the syringe pump is empty. Then detach and remove it from the pump and disconnect it from the infusion line. Wearing sterile gloves, remove the port needle from the patient and apply gentle pressure. Bandage the infusion site as per the institution standard of care. Some experts recommend covering the insertion site with sterile tissue and a bandage and keeping the site covered for 24 hours with betadine gauze, followed by 24 hours with dry gauze. Dispose of the infusion components, needles, unused solutions, and other waste materials in accordance with local requirements. Chapter 8. Post-infusion care. Vital signs should be monitored post-infusion in a healthcare setting. Upon completion of the infusion, the patient's status should be clinically assessed and observation may be necessary for longer periods if clinically indicated, particularly in patients less than 3 years of age. It is recommended to provide caregivers with instructions about the length of time the dressing may be left in place and how to watch for signs and symptoms of infection or complications such as swelling, pain, discharge or fever once home. In most cases, children can resume regular daily activities approximately 1 or 2 days after infusion. However, this decision should be made at your discretion. Give caregivers instructions on when to resume activities and details of any restrictions they should know about. It is also recommended to give caregivers guidance about what to avoid, including touching or scratching the device and direct trauma to the reservoir or any head injuries. For the first few days after infusion, public pools and other areas that may bathe the reservoir area with unclean water should be avoided to reduce the risk of infection. Chapter 9. Safety information. Contraindications. Life-threatening anaphylactic reaction to the active substance or to any of the excipients if rechallenge is unsuccessful. CLN2 patients with ventriculoperitoneal shunts. Solipinase alpha must not be administered as long as there are signs of acute intracerebroventricular access device leakage, device failure, or device-related infection. Warnings and precautions. Intracerebroventricular access device-related complications. Solipinase alpha must be administered using aseptic technique to reduce the risk of infection. Healthcare professionals should inspect the scalp for skin integrity to ensure that intracerebroventricular access device is not compromised prior to each infusion. Inspection of the infusion site and a patency check must be performed to detect intracerebroventricular access device leakage and/or failure prior to initiation of solipinase alpha infusion. Consultation with a neurosurgeon may be needed to confirm the integrity of the device. Solipinase alpha treatment should be interrupted in cases of device failure and may require replacement of the access device prior to subsequent infusions. Do not administer solipinase alpha if there are signs of acute intracerebroventricular access device leakage, device failure, or device-related infection. In case of intracerebroventricular access device complications, refer to the manufacturer's labeling for further instruction. In clinical studies with solipinase alpha, intracerebroventricular access device-related infections were observed. In these cases, antibiotics were administered, the intracerebroventricular access device was replaced, and solipinase alpha treatment was continued. Caution should be taken in patients prone to complications from intracerebroventricular medicinal product administration, including patients with obstructive hydrocephalus. Clinical and laboratory monitoring. Vital signs should be monitored before infusion starts, periodically during infusion, and post-infusion in a healthcare setting. Upon completion of the infusion, the patient's status should be clinically assessed and observation may be necessary for longer periods if clinically indicated, particularly in patients less than 3 years. Electrocardiogram, ECG monitoring during infusion should be performed in patients with a history of bradycardia, conduction disorder, or with structural heart disease, as some patients with CLN2 disease may develop conduction disorders or heart disease. In cardiac normal patients, regular 12-lead ECG evaluations should be performed every 6 months. CSF samples should routinely be sent for testing to detect for subclinical device infections. Pediatric population. There were no patients with advanced disease progression at treatment initiation who were included in clinical trials, and no clinical data is available in children less than 2 years old. Patients with advanced CLN2 disease and newborns may have decreased integrity of the blood-brain barrier. Effects of the potentially increased medicinal product exposure on the periphery are unknown. Anaphylaxis. Anaphylaxis has not been reported with solipinase alpha use during clinical trials. However, the risk of anaphylaxis cannot be excluded. Healthcare professionals should be aware of the possible symptoms of anaphylaxis, such as generalized hives, pruritus or flushing swollen lips, tongue and/or uvula, dyspnea, bronchospasm, stridor, hypoxemia, hypotonia, syncope or incontinence. As a precautionary measure, appropriate medical support should be readily available when solipinase alpha is administered. If anaphylaxis occurs, caution should be exercised upon re-administration. Sodium content. This medicinal product contains 44 mg sodium per vial of solipinase alpha and flushing solution. This should be taken into consideration for patients on a controlled sodium diet. Adverse reactions. The safety of solipinase alpha was evaluated in 24 patients with CLN2 disease who received at least 1 dose of solipinase alpha in clinical studies of up to 141 weeks. The most frequent adverse reactions observed during solipinase alpha clinical trials include pyrexia, low CSF protein, ECG abnormalities, vomiting, upper respiratory tract infections, hypersensitivity. No patients had to have their treatment discontinued due to adverse events. Very common adverse reactions with solipinase alpha included upper respiratory tract infection, hypersensitivity, irritability, convulsion events, headache, CSF pleocytosis, vomiting, pyrexia, CSF protein increased, ECG abnormalities, CSF protein decreased, needle issue. Common adverse reactions with solipinase alpha included conjunctivitis, device-related infection, bradycardia, dropped head syndrome, abdominal pain, oral mucosal blistering, tongue blistering, gastrointestinal disorder, rash, urticaria, feeling jittery, pain, device leakage, device occlusion. Device dislocation did not occur in clinical trials, and therefore the frequency cannot be estimated from the available data. Device-related complications included device-related infection, device leakage, device occlusion, dislodgement of the infusion needle. Convulsions are a common manifestation of CLN2 disease. and are expected to occur in this population. 23 out of 24 patients, 96%, treated with solipinase alpha experienced convulsions. The most commonly reported convulsion events were seizure, epilepsy, and generalized tonic-clonic seizure. 17% of total convulsion events were considered to be temporally related to solipinase alpha and were mild to moderate in severity. Overall, 6% of all convulsion events were considered related to solipinase alpha and ranged from mild to severe. Convulsions resolved with standard anticonvulsive therapies and did not result in discontinuation of solipinase alpha treatment. Hypersensitivity reactions were reported in 14 out of 24 patients, 58%, treated with solipinase alpha. Severe hypersensitivity reactions occurred in 3 patients, and no patients discontinued treatment. The most common manifestations included pyrexia with vomiting, pleocytosis, or irritability, which are not consistent with classic immune-mediated hypersensitivity. Adverse reactions were observed during or within 24 hours after completion of the solipinase alpha infusion and did not interfere with treatment. Symptoms resolved either over time or with administration of antipyretics, antihistamines, and/or glucocorticosteroids. Immunogenicity. Anti-drug antibodies were detected in both serum and CSF at 79% and 21% respectively in patients treated with solipinase alpha for up to 107 weeks. Drug-specific neutralizing antibodies capable of inhibiting receptor-mediated cellular uptake of solipinase alpha were not detected in the CSF. No association was found between serum or CSF ADA titers and incidence or severity of hypersensitivity. Drug-specific immunoglobulin E was not detected in patients who experienced moderate hypersensitivity adverse reactions. Remind caregivers to contact their healthcare professional immediately if they observe any adverse reactions. Contact BioMarin if you have any questions about the intracerebroventricular administration of solipinase alpha.